Good morning, welcome. We'll get started here in a couple of minutes, but we're glad you're here with us today. Good morning. We still have a few people trickling in, so we'll give it a few more seconds before we get started. Okay. Well, welcome. We're so glad you're here with us today. We're going to go ahead and get started as we have a very jam-packed, exciting agenda for you all today. My name is Lindsay Wyckoff, and I am the Director of Volunteer Community Strategy here at the American Cancer Society, and it's my absolute pleasure to welcome you today. We ask that if you have multiple people listening from one line, that you please enter your name and organizations in the chat so we can have a record of your attendance. Attendance for everyone else will be recorded automatically. All lines will be muted during the program, and we ask that questions be entered through the Q&A tab at the bottom of your screen. We will be taking questions during our panel discussion as time permits. As we get started, we would like to learn a little bit more about who's in our audience today. Please answer the poll and let us know what sector you represent. Thank you so much for doing that. Hopefully we'll get the results coming up pretty soon. There they are. Okay, great. Thank you so much for that. That information is so critical as we continue to plan these in the future. Before we begin our program, we want to recognize and thank our sponsors. Without the generous support of the Ohio University Comprehensive Cancer Center, the James Cancer Hospital, and United Healthcare, this program would not be possible. Also, thank you to the Ohio Partners for Cancer Control and Mountains of Hope Comprehensive Cancer Coalitions for their continued support. Here's our agenda for the day. We will start with a mission story, followed by our four presenters. And after the presentations, our speakers will join us for a panel discussion. We will conclude with some information on the American Cancer Society's resources and a few housekeeping items. The AAFP has reviewed navigating current issues in cancer, rural health, and deemed it acceptable for up to 2 enduring materials self-study AAFP prescribed credits. You will receive a certificate to claim your CEs within 2 weeks following completion of the post-event survey. Our objectives for today's event can be seen on the current slide. The planning committee members and speakers have declared that there are no relative financial agreements or affiliations with the organizations that may affect balance, independency, objectivity, or scientific rigor for this CE event other than those disclosed on this slide. Also, please know that slides will be available after the presentation and this event is being recorded. We begin each session by acknowledging the individuals who are directly affected by the topic at hand. Today, we are privileged to be joined by Penny Horner, a 15-year breast cancer survivor and current treatment for thyroid cancer. Penny is one of our colleagues at the American Cancer Society and serves as a development manager. She has been married for almost 40 years, is a mother to 3 children, and a grandmother to 8 grandchildren. Penny has graciously agreed to share her story with us. Welcome, Penny.
Thank you so much. I'm very honored to be here this morning. My story actually started back in 2015 when I received a diagnosis for breast cancer. And my family is spread across the country. So I documented everything via Facebook at that time because was our outlet at the new Facebook thing. So I have many people from all over that were reaching out to me. How are you doing? What can I do for you? Which is wonderful. So my posts on Facebook have been silly, educational, and serious. I always put a disclaimer, but most of all, my posts are my facts, my stories, and written by me. So my post from September of 2025 this year, I received a diagnosis of thyroid carcinoma stage 1. First initial surgery I had was the right gland. This means since I don't have a thyroid anymore because it's totally gone now, I don't have air quotes thyroid cancer. I have chosen to do the radiation iodine treatment because I have a high chance of reoccurrence because of the last gland removed showed a subtype of papillary thyroid cancer with follicular characteristics, nuclear features not encapsulated, with a tendency to spread to healthy nearby tissue in distant areas. The margin for my cancer was 1.9, right on the edge. And when a cancer patient gets this, they are now, we have my chart. So we are in that, we're digging deep, we are Googling for information. In my case, I went to the American Cancer Society because they have this wonderful app called ACS Cares. So I was lost. I had two different cancers, breast cancer and then thyroid cancer, and there was a big difference in cancer care. With breast cancer, I had an oncologist. With thyroid cancer, I don't have an oncologist. So I was lost. I didn't know what to do. And I went and I joined the ACS Cares app. I downloaded it on my phone. And I found people just like me that have been cancer survivors for the last 30 years of thyroid cancer. So we shared recipes, we shared jokes. And because of I'm going to be doing the RAI therapy, I am right now on a low iodine diet, not much fun. My body is in shock at times, thinking, oh my goodness, what are you not putting in here? I'm eating much healthier though, getting ready because I don't want to redo this again. So I call on November 21st is my glow day. I have always had a plan. I knew what my schedule was like for the next week or several months out. My plan that I know to be now have to fit in this blank space, but I can't see anything. My calendar now has someone else's timeline, not mine. Not knowing what's next is hard and causes some major anxiety. And now that my anxiety is at a new level while trying to find a good level for my new medication, my life has been shaken like I live inside a snow globe, except the little people aren't glued down. I have jokes about RAI. Have you ever seen the movie E.T.? My house is going to look like E.T. lives here. Someone is going to come and tent my house, place people in white suits with radioactive detectors are everywhere. Just imagine that. E.T. phone home, got my bike ready for the great escape. So then I went ahead and I wrote a bonus section on my Facebook page, more toward education and awareness and again what I'm facing. So I now have a more personal and even better understanding of how cancer patients feel when access to care is limited or maybe in some cases non-existent. The only place closest to me to treat for treatment that can administer RAI is either Morgantown, a 2.5 hour drive, or Front Royal. That can be up to a 1 hour drive depending on the Interstate 81. If you've ever been on 81, you know what I mean. This is a huge obstacle when needing to get good cancer care. Initially, I was able to see my PCP locally, but then needed to travel 30 minutes to see the surgeon that came highly recommended. And of course, I want someone that specializes in the removal of my thyroid and would know the areas not to venture toward. So I thought, no big deal, only 30 minutes. I'm cool with that. My biggest aha moment was about the RAI when it's administered, the patient potentially might have to drive for hours to get home to isolate themselves. You can't even stop to use a bathroom or get food. You shouldn't be around others in close proximity. This is one way ACS plays a critical role to help overcome these obstacles. By providing and promoting these services, cancer patients feel supported. I now know. Another obstacle that I faced was due to the lack of specialists available. I waited almost an entire year to have the second surgery. I'm lucky in a sense. I could have gone elsewhere, but I chose to stay closest to my home. Many people don't have the luxury to make a choice of where they want to go for treatment. Health insurance is an issue. If I had felt the need to handle this sooner, I could have called ACS. They would have answered my questions and I would have gotten help sooner, probably further from home. I utilized ACS's 800 number to find a cancer center where my mother could get treatment. They even told me about Relay for Life, cancer support groups, and when the moment came, grief counseling. My mother received a cancer diagnosis in 2003 of colon cancer. She fought and fought and fought, but without ACS's help, we wouldn't have been able to, we would have been financially unstable because we had to travel 4 hours from home. So we were able to stay in a Hope Lodge, which helped us significantly. When I received my new cancer diagnosis, I tried making it sound like it was no big deal, just a simple one-time surgery, then done, cancer-free. It also helped me to make sure that this wasn't going to shake my loved ones' lives. I told them what I had heard. If you must have a type of cancer, that thyroid is the one you want. Cancer is cancer, it's not good. I like the comfort of getting care close to home. And my first cancer diagnosis, breast cancer, 5 minutes or less, I was where I needed to be. I have truly experienced that access to care is not easily accessible where I live. It also means much more. Now I must travel far. What would happen if I didn't have transportation? It's not like I could get RAI treatments and use public transportation. That would mean I would be ruining other people's thyroids. You can't do that. So my differences between breast cancer and thyroid care. Breast cancer, I had a cancer care team, a care plan. I was given a cancer journal from the Nurse Navigator. She suggested I write any question that I might have to share with my loved ones so they were updated along the way. I remember the first question in the journal, what do you want the outcome to be? I was thinking, well, that is the most ridiculous question. I placed the journal on the coffee table and walked away. That question at that time really bothered me. I sarcastically would say, what do you think I want the outcome to be? And so a couple days later, the journal was still on the coffee table, still open to the same page. I picked up the book and I wrote the words, I want to survive. At that moment, I knew I was a survivor. I had a great team supporting me. Care for thyroid cancer, I have a surgeon and now endocrinologist. No oncologist to follow me for the thyroid cancer, which I thought was very strange. I always thought if you had cancer, you were followed by an oncologist. I learned it doesn't always work this way. This had me feeling confused and a little lost. Someone that had never experienced cancer before probably won't feel this way. They won't know any different. But I experienced another cancer that was treated totally different. And it was weird, I thought. 2 minutes, okay. Thanks, Susie. I felt like I didn't have a good solid support system in place. However, I knew where to go to find the support I so badly needed. The American Cancer Society has an app called ACS Cares, which I mentioned earlier. I was able to connect with other survivors like myself and interact as much as I felt comfortable with. Some of these survivors have been thyroid cancer free for more than 30 years, but ACS also has some amazing events that are very supportive and that can promote a sense of healing. I highly suggest everyone attend and become involved in your local events. Here's my plug. It means the world to our cancer survivors that they see our medical professionals at these community celebrations. You are a huge part of cancer survivors' lives, and they also would like to celebrate you, their reason why they survived. You are all invited to any of my Relay for Life events. Jefferson County presented by Shepherd University on April 18th from 12 noon to midnight. And this is the home of an American Cancer Society researcher whom received her first research grant from the American Cancer Society, Dr. Mary J. Hendricks. Relay for Life of Berkeley County, West Virginia is on June 6th at Martinsburg High School, Coburn Football Field. Come see and mingle with our Faces of Hope nominees and our Youth Gold Together ambassadors. I can promise you will want to come back year after year. Both these fundraising events have a huge community presence and welcomes everyone. I always have a gentleman that always comes up to me at closing and says to me, "Someday we will be giving out I have never had cancer awards." My response is always, I will be happy to help plan that event. Thank you.
Thank you so much, Penny. We really appreciate you sharing your story. And as one of your colleagues, it's so lovely to hear from you. And thank you for all the work you do for Relay for Life as well. We are very excited to share our first presenter today will be Adrienne Duckworth. Adrienne Duckworth is a West Virginia native and two-time graduate of West Virginia University School of Nursing, earning her BSN in 2012 and MSN in 2014. Since 2014, she has worked as a nurse practitioner specializing in thoracic and head and neck oncology at WVU Medicine, where she directs the survivorship program and leads regional APPs in medical oncology. Adrienne was named WVU Medicine Advanced Practice Professional of the Year in 2024 and promoted to Adjunct Clinical Assistant Professor in 2025. Adrienne, welcome and thank you so much for joining us today.
Thank you for having me. So I'm going to speak briefly about WVU Medicine's approach to navigating cancer care in the rural population. So I have several roles, as mentioned. My primary job is as a nurse practitioner in the Thoracic Medical Oncology Clinic here in Morgantown. I also help to I direct our survivorship efforts at the Mary Bab Randolph Cancer Center. And I help to manage the APPs across the regional sites of WVU Medicine. So if we can go to the next slide, please. So what makes West Virginia different than other states with significant rural areas or populations? In 2023, the Economic Research Service under the Department of Agriculture published a report that was called Characterizing Rugged Terrain in the U.S. And they developed two nationwide classifications of census tracts, or these were introduced, area ruggedness scale and the road ruggedness scale. And West Virginia had the largest share of people living in highly rugged census tracts, which was 15%. The road ruggedness scale is a 5-category measure created by the Economic Research Service, as I said already, that classifies census tracts based on changes in the elevation while traveling on the roads. And as you can see from this graphic, West Virginia leads the nation with 80.7% living in slightly, moderately, or highly rugged areas. And when ruggedness and rurality intersect, there are unique challenges that are presented to those patients or to those people, including transportation, access to goods and services, and especially healthcare. So we can go to the next slide, please. So this is actually a map of the WVU Cancer Institute sites. As you can see, we've been trying to increase our catchment area over time. And they actually have them divided into regions now for different management purposes. So if we can go to the next slide, please. So we are trying to provide care closer to home. Our regional site care expansion has increased throughout the early 2020s with further expansion planned as the years progress. The connections to WVU Medicine's main campus in Morgantown are through shared management, if necessary, if patients feel that they want to have a primary oncologist at a tertiary center, versus they can be managed by a local oncologist, always come for a second opinion or at various points in time. We also have an integrated electronic medical record, which helps us to be able to ensure those smooth transitions when patients do need to receive care at various sites. And we are working on expansion of clinical trials across the system to improve access and representation of the population, as a lot of rural or rugged rural areas are not well represented. We can go to the next slide, please. So I was also asked to speak briefly about the survivorship program that kind of kicked off survivorship here in Morgantown. So we were funded through the Cancer Moonshot Initiative to do a study with lung cancer patients. And this was with patients were seen in a multidisciplinary clinic visit with an APP, PT and OT, social work, and a dietitian after completing their treatment for lung cancer. And the patients were assessed for unmet needs at that time. And then further care and recommendations were made to improve the overall health and survivorship. And then patients were referred back to sites in their local communities for follow-up. So all of our patients actually had at least one unmet need. I want to say that most of them had 3+ unmet needs at the end of their cancer care. So this was all about trying to make sure that patients were set up to succeed after they finished those very frequent visits with their providers. And I believe that is actually the end of my presentation.
Hi there. I think I'm next on the docket. My name is Dr. Ashley Roscoe. I am an oncologist at The Ohio State University. So I'm excited to talk to you a little bit about access for rural care when it comes to bone marrow transplant. And so was very enthusiastic about talking to you all today about access because it's a complex topic, and I definitely resonated with Penny's introduction, where she talks about rare cancers and navigating complex interfaces. And also, I was just recently down at WVU at Morgantown, and also want to reflect on Adrian's the idea about different areas and rurality is an important aspect of how to be able to better reach patients. And so I'm going to talk to you a little bit today about one of our studies, which was an ambispective study. We looked both at retrospectively at patients with multiple myeloma at our institution, and then also prospectively for an intervention. And this study was called Moving Mountains and Navigating Bone Marrow Transplant Access. So I'm going to take a moment just to talk to you a little bit about what multiple myeloma is. Multiple myeloma is a rare cancer. It's less than 1% of people who are diagnosed with this type of blood cancer. But also, importantly, the leading indication for bone marrow transplant for patients is multiple myeloma. So it's a very rare cancer, but the most common indication for a transplant is multiple myeloma. This is looking at the CIBMTR data set, and you look at over time, in the past 20 years, there's been this increased utilization of transplant. Bone marrow transplant has been the standard of care for decades for patients diagnosed with multiple myeloma. We've been doing transplants since the late 80s, so for many, many years, it's been the standard that all patients newly diagnosed with multiple myeloma who are fit for a transplant, which is a lot of patients, they should be evaluated at a bone marrow transplant center in order to potentially benefit from getting a bone marrow transplant. So, so you can see over time, there's been this increased utilization of bone marrow transplant, and there's also an increased utilization among aging adults with multiple myeloma to undergo a bone marrow transplant. Just so we're clear, multiple myeloma is a disease of aging adults. And so it's kind of important to know that more people who are older have access to a bone marrow transplant. So we're going to go to the next slide. So, but it's also important to recognize that despite bone marrow transplant being the standard of care for patients, for decades at a time, the bulk of people who are diagnosed with multiple myeloma do not receive a transplant. So if you look at this, about 11% of patients, receive a transplant, and 90% of patients don't ever receive a transplant. And this is also kind of looking over time. If you look at the columns, the red columns indicate people who do not receive a transplant. And then the blue at the bottom of these columns indicates the number of people who do receive a transplant. And you can say, well, this is increasing over time, that the number of people that are receiving transplant, but you can very much see that most of the patients diagnosed with multiple myeloma or rare cancer don't ever receive this care. And relevant to this conversation, there was a great study that was done by Dr. Alham Adini a couple of years back, and it really said, here are the people that are least likely to receive a transplant. If you're older, if you are a minority, or if you're of a lower socioeconomic class, and that was kind of defined pretty loosely, or if you live in the community. But the issue is most people diagnosed with cancer live in the community. Most people who have a malignancy are started with their primary care doctors, referred to an oncologist within their community, which is usually within the concept of about 30 minutes. But the problem with this, particularly for those who live in the rural areas or in community areas, is that this is an uncommon malignancy, and it definitely requires specialty care. And it also requires oftentimes the interface with a tertiary care center. Next slide. And what we also know about multiple myeloma and those that need a bone marrow transplant, patients with myeloma have better outcomes, better long-term survival at higher volume tertiary care centers. And so this graph is pretty startling. This is why this is that if you look at on the bottom on these dashed lines, the orange and the green, those are both community oncologists. Okay, so patients diagnosed with myeloma seeing their local community oncologist. And then the blue line, okay, is survival for those seen by a myeloma specialist. Okay, and so those are pretty wide curves and showing that patients that have myeloma and are seen by a comprehensive cancer center or a myeloma specialist has a high volume practice, their survival is going to be better. Okay. And then if they're at a lower volume or oncology, the survival is less. And part of that has to do with the changing atmosphere of multiple myeloma, which is an ever-changing field, the need for transplant or cellular therapy. But also there were issues why people didn't ultimately go to a high volume center is they're related to age, related to insurance issues, related to being married, and also, or like having a social support system. And then also this relationship to distance to a tertiary care center. Next slide. So there was a study that was done that said, actually, okay, if you look at people, there's over 200 centers across the United States, and that are transplant centers that could do a transplant for these, rarer cancers. Multiple myeloma is one of them, but there are many other cancers that require evaluation for bone marrow transplant, like acute leukemia, lymphoma, and things like that. So in this study, they said, okay, actually, access to transplant services appears to be quite high in the United States. And we're very fortunate if you're 18 years or older. Half the population lives about 30 minutes from a transplant center. 78% of the population lives within 90 minutes of a transplant center, and then 94% of the population 80 years or older, or excuse me, 18 years or older, live within 180 minutes of a transplant center. And so my argument to this is, geography doesn't equal access. Okay, so I think, and especially for the idea, like in listening to Penny's story, really resonated with the idea. There's so many nuances to these things. 90 minutes doesn't sound like a short amount of time, but what if you have to go there twice a week? And what about the idea that when you're kind of navigating some of these, very difficult, complex tasks, geography alone is not the solution to saying, well, it's close enough. We have a center that you could go to. Access to complex cancer services is a lot more, a lot more complex than that. So next slide. And so in our study, we, kind of the background of this, and I'm an Ohioan all my life, so I've, trained in Ohio, lived in all aspects of Ohio, and I'm now currently in the center of this map in Franklin County. And I definitely didn't feel that the patients that I was reaching to, were primarily coming from the metropolitan area, right? Although Ohio State is the entire catchment area for the state of Ohio. But I also recognize that many of my patients were coming from 2 hours away, some of them from Northern Kentucky, West Virginia, and then also from the southern states or the southern counties. And what we recognize that our myeloma outcomes are influenced by race, ethnicity, age, socioeconomic status, and geographic location. And also recognize that rurality plays is a big barrier when it comes to being able to reach patients, particularly within Southern Ohio and some of the other rural communities, not just in Southern Ohio, but throughout the areas that we were not necessarily reaching or interfacing on a regular basis. And again, most of Americans live in a rural area, right? So like, especially in Ohio, Ohio is considered to be one of the fourth largest rural areas, where a significant percentage of our population lives in rural areas. So fourth largest rural population. And so for me, the degree to which these factors, socioeconomic status, race, age, rurality, influence transplant access was a major concern for me for our patients in creating better access. That was not just geographic access for our patient population. Next slide. So I created a study called the Moving Mountain Study, and this was really to be able to increase access for bone marrow transplant for patients, for vulnerable patient populations, for people diagnosed with a rare cancer. And so the vulnerable patient populations were older adults with myeloma, those that live in rural counties or within Appalachian counties, or those that are Black patients with multiple myeloma. So those are the populations considered to be vulnerable because they have lower access to transplant and inferior outcomes when it comes to overall survival. And so we said, okay, so part of this, what we're going to do is identify and work with some of the community centers, and I'll show you that on the next slide, to be able to say, we want you to have kind of direct access to us when it comes to myeloma transplant, and also the ability to offer virtual bone marrow transplant consultation with a tertiary care doctor. So for us to say, instead of, if you're in the community, which again, most patients are diagnosed with myeloma in the community, let's, in the context of, Zoom and virtual, actually, we have the ability to see patients to say, okay, I have all your data from your community center. I have a good idea about your cancer diagnosis or what needs to happen. Let's save you time, travel. A lot of times people are working night shifts. A lot of times people, the idea of having to take off work, having their caregiver to take off work to spend an entire day traveling, or just, to kind of fit in a visit on perhaps even a lunch break. We did that for patients to say, let's have a consult via televideo. So in order for us to talk about transplant. And so just to hear the information to talk about candidacy for a bone marrow transplant. And then we also had patient navigators that would send them information in advance. We would work with community centers to be able to get education and instruction. So we can talk a little bit about kind of this communication and coordination and things like that. And then we can kind of decide together if they want to be able to get a transplant. They continue to get treatment locally within their community center. And when the time is right for them to come up and get a transplant, then we'll expedite that evaluation. We're already connected without them ever physically having to come see us. So it just basically minimizes visits, expedites the evaluation, and then some of their post-transplant care could also be offered virtually. Next slide. And so this is just to give you a sense of like what myeloma incidence looks like. And so if you can look, these kind of dark blue indicates the incidence rates for multiple myeloma. And if any of you live in Ohio or Ohioans, you can estimate that a lot of these counties are rural counties throughout the state of Ohio, in which we see a lot of myeloma. Okay, there's a lot of farming, there's a lot of things going on there, environmental exposures. We see a lot of myeloma within those counties. And then also within the southern counties of Ohio. If you click next slide, there's an animation here. So, but what we also recognize is within the studies, we kind of sought out centers specifically within the Appalachian areas, which represent about 13% of the counties or of the population, for us to be able to have kind of this targeted interventions to say, here's kind of a direct access for us, for you guys to be able to contact us. So that way we can kind of create stronger channels between these centers. Next slide. And so, next slide. Yeah, thank you. So what was important, kind of taking the take home for this is that we looked at two important factors that we looked at this. We looked at transplant receipt, right? Like we first looked at 1,700 patients or nearly 1,800 patients who was most likely to get a transplant. And then we also looked at overall survival. So this is the retrospective piece of this study. And so we said, when we looked at 1,800 patients, 65% of them received a transplant. This is a transplant center, right? So like, of course, we are, if you look at the whole data, we have about, 11% of patients that receive a transplant. But at our institution, we see all kinds of myeloma, and 65% of our patients receive a transplant, which makes sense at a transplant center. And mostly those patients were metropolitan. But what we also found for the receipt of transplant, what we also found for those patients is that unlike metropolitan status or non-metropolitan, whether or not you're rural, our transplant access was influenced by their age, was influenced by race, and it was also influenced by this Yost index, which is a composite of household income, poverty line data, home value, rent, mortgage, education, unemployment, and occupation. It was a score per a geographic unit. So not so much if you're metropolitan or non-metropolitan by RUCA scoring, but really about kind of this Yost index, about the socioeconomic score that kind of captures each of these variables into it. And then we also found not only was higher socioeconomic status by the Yost index, but also the Yost index can predict, whether or not the receipt of transplant, and also Yost index had an improved overall survival. So it's not just rurality or geography, but having this kind of influence of education, income, unemployment that influences the receipt of transplant and overall survival. Next slide. But also what we saw for our virtual consultation of the piece, where we said, okay, we're going to, put it out there, create these strong channels to say, and offer patients who we've never seen, say, look, we're going to assess you virtually to see whether or not we can talk about getting you into a transplant. So when we offered that to patients, because there was did surveys first, and we offered that to patients, half of them said, actually, I would rather come in and talk with you. So we said, so half of the patients, when we offered them virtual consultation, they said, actually, I'd rather come in anyways and see you. And of that population, what we were able to see is that we were able to reach 42% of our patient population being virtual consultation was non-metropolitan, and 15% of our population was from an Appalachian county. But importantly, when we offered virtual consultation, we didn't see any differences in transplant utilization by geography, by Yost index, by race or age. So we were able to mitigate and kind of level the access by offering some of this virtual consultation. And if you look at this consort diagram here, so some of our virtual consultations said actually you don't have active myeloma, you have smoldering myeloma, you don't even need a transplant. Some of our patients, only one patient didn't have access for us to be able to do a virtual consultation, so we couldn't see them for a part of the study. When we assessed them, so virtually, 6 of them, we said you're not eligible for a transplant for different reasons. So we said so save you time and money, you don't need to come see us. You're not a candidate for transplant, either related to their disease or related to comorbidities or fitness. But of those patients, 24 of those patients were eligible for a transplant, and we saw them virtually. 2 of them, we collected their stem cells and stored them for a later transplant. 15 of those patients actually received a transplant, and 7 of them heard the information, were educated about them, and they decided not to have a transplant. And so, again, saving time, creating channels, and being able to allow patients to see a tertiary care specialist and also stay in their own home. Next slide. So where I think that the future when it comes to creating access, when particularly when as it applies to communities and patients living in rural areas, is through patient navigation. And so transplants and just like we had heard about rare malignancies and things like that, oftentimes requires and there's more coming on the horizon. So it's not just transplant, it's CAR T, it's cellular therapy, it's all these things and clinical trials. This is complex. There's structural, cultural, financial, educational, systematic barriers to being able to do these things. And I think that through patient navigation, which was an important part of what we incorporated into our studies, is that we had, a middle person between us, the community centers, and the patients to say, here's a phone number to contact me so we can make sure we have issues about travel, transportation, parking, about what to expect on the phone calls. And we know that patient navigation can reduce barriers, help reach underserved populations, early detection, help with diagnosis, treatment, and survivorship. So, but I think also how patient navigation can be utilized is to be able to take these types of interactions and using virtual consultation to reach people so that they have information and education, that they've had the opportunity to be able to see specialists, especially when it comes to rare malignancies or things that are less common, that definitely require, having some type of interface with a tertiary care hospital. And that my next slide is thank you all for listening, and I'm happy to answer questions in the chat and look forward to the panel.
Thank you so much for that presentation, Dr. Roscoe. As someone who was born and raised in Ohio, I did not consider us the fourth largest rural population in the country. So among other incredible facts and information, thank you for sharing all of that. Presenting next is Samantha Wertz-Pelter. Dr. Wertz-Pelter is a postdoctoral associate at the University of Pittsburgh School of Medicine in the Division of Hematology Oncology. She obtained her MPH and PhD in Health Promotion Sciences and a graduate certificate in aging at the University of Arizona. An active member of the Junior Cancer and Aging Research Group Board and the Cancer Prevention and Control Research Network, Dr. Wertz-Pelter is largely interested in addressing cancer health disparities faced by older and rural populations. Her research focuses on addressing barriers to practicing healthy lifestyle behaviors and promoting adherence to diet and physical activity guidelines for cancer prevention and survivorship. Welcome, Dr. Wertz-Pelter. We're happy to have you, and I'll turn it over to you.
Great. Thank you so much, and good morning. Thank you to the American Cancer Society for the invitation to speak with you today, and I'm looking forward to the panel discussion here in a few minutes. Like Lindsay mentioned, my background's in behavioral interventions, and so a lot of the work that I do is with the focus or the goal of improving adherence to diet and physical activity guidelines for cancer prevention and survivorship. And so today I want to share a little bit of background regarding health behaviors in rural areas and also some considerations for how we can improve access to and tailoring of lifestyle interventions for rural communities. So next slide. So 1 in 5 lifestyle behaviors, or 1 in 5 cancers is related to a lifestyle behavior such as physical activity, diet quality, smoking, or alcohol consumption. And we know that improving healthy lifestyle behaviors is associated with better outcomes, particularly for cancer. So decreased cancer-specific and all-cause mortality and morbidity, decreased risk of cancer recurrence in the future, and decreased risk of secondary cancers as well. And then also improved physical functionality, symptom management, health-related quality of life, and fatigue. And so we know that lifestyle behaviors are really important, but next slide. We also know that despite all the strong evidence we have for the benefits of meeting lifestyle guidelines, adherence overall is very low. So for example, only 18% of cancer survivors are meeting physical activity guidelines overall, and 57% of cancer survivors, so over half, are not doing any physical activity in their leisure time whatsoever. So not only are they not meeting the guidelines, they're not doing any activity that would help them meet those health benefits for healthy lifestyle behavior. So that's overall. When you get to rural cancer survivors, however, and patients, we also know that they're even less likely to adhere to lifestyle recommendations. So rural cancer survivors are over 30% more likely to report being completely physically inactive. So why do we see this disparity in lifestyle behaviors? One, rural populations face several barriers, including the ones you see on the right, but others and the others that have been mentioned today. And I won't go into those barriers today since we've already heard about it, and I'm sure we'll hear a little bit more. But another reason is that few interventions have been designed or tailored for the needs of rural populations. So we did a study in 2023, a systematic review that identified there's only been 2 randomized controlled trials in the United States that have been conducted specifically focused on the implementation of lifestyle behavior change interventions among rural cancer survivors. So these interventions just aren't being conducted, or they hadn't been conducted as of 2023. And so we have a lot of work to do as far as how can we tailor interventions that meet the needs of rural communities rather than just bringing interventions that have been shown to be effective in urban communities into a rural setting, because that's not going to be effective. So next slide. There are several opportunities, I think, for tailoring interventions or bringing interventions to a rural community. And one big push right now that we've already heard a little bit about is telehealth and other digital health tools, because these offer an opportunity to bridge the gaps in care between rural and urban cancer survivors, especially with that remote opportunity for care. So digital tools such as using the internet, electronic wearable devices, social media, these all offer ways to disseminate health promotion materials and education remotely to cancer patients and survivors. And tools like MyChart, like Penny mentioned earlier, offer opportunities for patients to better self-manage and track their health over time, or to connect with providers. Given the barriers that rural residents face to accessing in-person health behavior programming and resources, remote delivery, like I mentioned, is one strategy for delivering this information. But there's often been this disparity described as the digital divide. So we need to understand and consider how does access to digital health and technology in rural areas impact their access to care. I'm going to argue that the shift to reliance on telehealth and remote technology during the COVID-19 pandemic may be starting to shift that digital divide and may have been giving us an opportunity to improve the knowledge and access of digital devices in rural populations. So these graphs use data from the NIH-sponsored Health Information National Trends Survey, or HINTS for short. And this is data that was collected in 2022, so the first iteration of the survey collected after the start of the COVID-19 pandemic. So here we're comparing digital technology access and use amongst cancer survivors 60 years of age or older by rural and urban status. The red bars represent 585 urban cancer survivors nationwide, and the blue bars represent 125 rural cancer survivors. So the main takeaway here is that there are no differences in internet use or mode of access, digital device ownership, or social media use in the previous 12 months of when the survey was taken between rural and urban cancer survivors. So again, potentially we're seeing a shift in how rural communities are accessing digital technology. Overall, most older survivors are utilizing the internet, and they predominantly utilize a high-speed service to connect. 95% of older adults report owning at least one type of digital device, and more than half own more than one. Regardless of residential status, older survivors reported high rate of smartphone ownership, and only 5% of older cancer survivors report not owning any digital device. And though this isn't significant, there are some potential variations in digital device ownership, like you can see between rural and urban communities. And so this may be something that would arise in a larger sample, but here we see there's potentially lower tablet device ownership in rural communities, and also higher basic cell phone ownership. So for any interventions that are utilizing these types of digital technology, or clinics that are using telehealth, these may be some things to consider. Rural cancer survivors may need some additional support or instruction if these are devices they haven't utilized before, or technology that they haven't utilized, such as apps on a smartphone. And then finally, the one on the right, you can see 66% of older survivors also report using social media. So that's another avenue potentially. Next slide. So here I want to share another consideration for implementing and tailoring supportive care for rural cancer patients and survivors. So this is the catchment area for the University of Pittsburgh Medical Center, the Hillman Cancer Center here in Western PA. And so this is looking at rurality in 2 different ways. So oftentimes rural as a definition encompasses a wide range of experiences, but it's categorized as a dichotomy with urban. And so if we want to understand and adapt to the variation that you see here in rurality, we need to understand how we can tailor interventions, not just for people living in RUCA codes 4 through 6, but how can we also reach someone with a RUCA code of 10, which is the most rural? And so these are looking at, again, rurality in two different ways. So the RUCA codes are on the left and the RUC codes are on the right. And again, we see that there's this variation. RUCA codes have 4 through 10, which are all considered rural, and RUC codes have 4 through 9, which are all considered rural. But there's a lot of variation there as far as resource access, social connection, health outcomes. And so just as you can see, looking here at our catchment area, there's a lot of variation in how patients and survivors are going to be accessing resources, how far they have to travel to get to the cancer center. You can see the black dots are where some of our community network sites are. So you can see even with those sites, some patients still have a long distance to travel just to get to one of the tertiary sites. And so this is something to consider for future interventions. Next slide. I want to just quickly share one trial that we're working on. This is the Nurse Amy trial. This is currently running, so we don't have results from this study yet, but this trial participants are given a tablet device to test the effect of a supportive care program on overall survival amongst rural advanced cancer patients. So these are all patients that have been diagnosed in stage 3 or 4. Participants in the study are given a tablet that's enabled with cellular data so that they can use the tablet daily. And on the tablet, this is the program on the bottom. This is the supportive care program that is helping with symptom management. Each day, they are asked to complete a daily symptom questionnaire, and then based on their level of sleep distress, fatigue, pain, they're given an empathic response from our device, and then a tailored intervention is offered to help manage that symptom. And so you can see 60% of the time they're offered a physical activity intervention to help with management, and they can choose to complete that intervention or not. This is a 2-year follow-up for the study, and this next slide that I'm going to show you is just looking at the first 6 months of tablet usage. And I'm showing you this study because it offers a good opportunity to potentially examine the usage of digital technology during an intervention and to compare that usage by level of rurality to see if there are any differences. So here I'm showing you a comparison of tablet usage by micropolitan participants in the dark blue, which I've categorized as RUCA codes 4 through 6. And then the more remote or isolated participants, which are RUCA codes 7 through 10, which is in that light blue. So in the graph, you can see on the left, this is percentage using the tablet at least once a week. And then on the bottom, this is the number of weeks on study up to 6 months. And you can see that light blue line, the more rural group, is actually utilizing the tablet more from the very beginning of this study all the way to 6 months. And so at week 26 or 6 months on study, you can see 50% utilize the tablet at least once during that week. And then compare that to the micropolitan group or the less rural group, you can see about a third utilized it in that week 26 period. Another thing we've learned from this study is that people living in the more remote areas are actually very willing to participate in a digital technology-based intervention. And so the more rural group represented about 20% of those who screened for eligibility, but they actually represent 25 of those who have been consented. So we're doing a great job of reaching this community, and they're interested and willing to participate in technology-based interventions. And then, like I said, participants living in those more rural areas are more likely to utilize their tablet on a regular basis. Next slide. So these are just some considerations for how we can better reach rural communities potentially in the future with lifestyle and supportive care interventions. One, I think we need to consider how we're reaching rural participants and what scope of care can we have for as far as rehabilitation care, specialists that they can talk with. What do we need to have in person versus what can we provide high quality care using telehealth or remote technology? That second option is innovative ways to connect and support health. So there's a lot of new technology that's coming out every day. And so we need to figure out what can we bring to the community? What are they interested in using? And how can we adapt the care that we give in a way that is going to be beneficial and of high quality using these technologies? And then finally, we need to tailor interventions for rural communities. It's not as easy as just transporting something that worked in an urban community into a rural setting. There's a lot of variation, a lot of differences in resource access. And so we need to use more of a community-based approach to build these interventions or tailor these interventions to participants in rural areas. So with that, I want to say thank you, and I'll be looking forward to your questions as well.
Thank you so much, Dr. Wirtz-Pelter. Your presentation really showed that meeting people where they are works, and it's so great to see people open to technology that could really close the gap for those in rural communities. Our final presentation before our panel will be from Dr. Haima Polimara. Dr. Polimara is an internist with over 20 years of experience in the field. She received her medical degree from, I know I'm going to mess this up, Adra Medical College, NTR, and completed her residency in internal medicine at Penn State College of Medicine. Dr. Polimara is a board-certified internal medicine, hematology, and medical oncology professional. She is actively involved in research and has contributed to the Sustainable Development Goals through her work. Dr. Polimara is also an associate professor at Penn State College of Medicine, Hershey Medical Center, and Hershey Medical Center, where she continues to make significant contributions to the field of medicine. She has received several teaching and research awards, including PA Medical Society's Top Physicians 40 Under 40 Award. Thank you for being with us today, and I'll turn it over to you.
Thank you, Lindsay, for the introduction. Good morning, everyone. It is an honor to be part of this panel discussion today. So, as Lindsay mentioned, I'm Haima Polimara. I'm an oncologist and associate professor at Penn State Cancer Institute. My research interests include development of biomarkers and promising cancer treatments, but more importantly, making sure these advances reach all communities. Growing up in the rural area with limited access to healthcare, improving rural health is deeply meaningful to me. So improving rural health needs multi-pronged approach. And one of the approaches that we have taken is about ECHO model. So today I will be sharing about how we are using the ECHO model to expand access to cancer clinical trials. Next slide, please. So why this work is important? Clinical trials bring hope. Clinical trials are the way we test the new cancer drugs and make new cancer treatments, and ultimately we improve the patient outcomes. But when looking at the current enrollment landscape, only about 7% of the adults with cancer participate in the clinical trials, and rural participation is even lower. 20% of the clinical trials fail due to lack of accrual. And interestingly, 55% of the patients say yes to the clinical trial participation when asked. So the problem here is lack of opportunity. And individuals living in rural areas have a 17% higher death rate from all cancers combined. So it is extremely important to bring these clinical trials closer to these communities. Next slide, please. The ASCO State of Cancer Care report in 2025 emphasized that improving patient access to cancer clinical trials is a fundamental ASCO priority because clinical cancer research is the essential link transforming biomedical discoveries into meaningful progress in cancer care and patient outcomes. Despite these advantages, many barriers exist. So if you look on the right-hand side, some of the common barriers for clinical trial participation are lack of awareness among providers and patients, and logistical challenges like lack of access to the clinical trials, financial burden, travel, accommodation, distance, and strict eligibility criteria are some of them. Next slide, please. So during my fellowship, I got an opportunity to co-author ASCO educational book titled Geography Should Not Be an Oncological Destiny. So in this paper, we emphasized what are the barriers the rural patients face, and also we discussed about some of the interventions to deliver care. Those are like outreach clinics, digital health technology, increasing collaborative workforce and research funding. And we also described about ECHO model to improve the education of the providers and also improve the clinical trial access. Next slide, please. So now as a faculty, I am serving as the physician lead for the Pennsylvania Cancer Clinical Trials ECHO Initiative. This is a collaboration between Pennsylvania Cancer Coalition, Penn State Cancer Institute, and Project ECHO. So the main aim of this initiative is to create a learning community between community providers and academic experts, and we can use the ECHO model to expand the access to clinical trials across the entire Pennsylvania. So this is truly a team effort, and our cancer clinical trials collaborative work group included public health officials, clinicians, researchers, nurse navigators, APPs, and many more. Next slide, please. So for those who are unfamiliar with ECHO model, ECHO stands for Extension for Community Healthcare Outcomes. So ECHO moves knowledge, not the patients, and the essence of ECHO is teach one and reach many. During the ECHO sessions, the academic experts and the local providers join on a virtual platform, and during these sessions, there will be a 15-minute flash talk followed by a case-based discussion. During these sessions, academic experts share their best practices and the local providers share their real-world experiences in their communities. So the learning happens in a collaborative way in a all teach, all learn fashion. So this model was initially implemented by Dr. Sanjeev Arora in 2003 in New Mexico. And since then, ECHO model has shown great successes in improving several healthcare outcomes like cancer prevention, screening, survivorship, smoking cessation, etc. But this model was never implemented in improving cancer trial education or outreach. So we adapted this model to improve the clinical trial access. Next slide, please. So we planned for multiple pilots, and pilot 1 is focused on building knowledge and confidence with a goal to educate and empower rural providers on cancer clinical trials. So we designed a 5-session virtual curriculum, and the topics included clinical trial fundamentals, how to enhance the partnerships, what are the successful recruitment strategies, and how we can broaden the participation, and how APPs can be the site PIs, and what are the community outreach and education resources. So actually this program ran recently from September to November 2025, and we completed our last session last week. And the participants included physicians, nurses, nurse practitioners, physician assistants, pharmacists, research staff, social workers, community health workers, and patient navigators. We conducted pre and post surveys, and actually we have to analyze the post survey to know the changes in the knowledge and awareness and barriers. But we got the results from pre-survey, and what we have noticed as the top barriers for providers in promoting cancer clinical trials and the patients' barriers according to providers came out as lack of awareness about the clinical trials, need for more training, and travel and accommodation costs. So by using the ECHO model, we are planning to implement the strategies to tackle these barriers. Next slide, please. So with the improvement from the pilot 1, we will go on to the pilot 2, that is about bringing clinical trials to the communities. This is largely part of my WIN Career Development Award. So here we are planning to expand the cancer clinical trial access for underserved and rural communities by strengthening the partnerships between academic institutions and community-based sites. So Dr. Joshi is going to be my grant mentor, and we will be using the Project ECHO as a recruitment tool. And Penn State Cancer Institute, we are located in the central Pennsylvania, and our catchment area has several rural Appalachian counties. So we are planning to build partnership with the community providers and know what kind of clinical trials their patients need the most. And we will bring some of my clinical trial and my colleagues' clinical trial close to them. So we will integrate patient navigation resources, referral pathways, and mobile research units to accomplish this goal. So finally, the lessons learned from pilot 1 and pilot 2 and the successes, we will try to implement this ECHO model throughout the entire Pennsylvania in collaboration with the Pennsylvania Cancer Coalition. Next slide, please. So the key takeaways from my talk are enhancing access is enhancing hope, and ECHO moves knowledge and not people, so we can bridge the rural and academic care through shared learning with this model. Primary care and community providers are key partners in expanding cancer clinical trial. And improving diversity is not optional, it is essential to ensure trial results apply broadly and equitably, and geography should never be an oncological destiny. Next slide, please. Thank you, and I look forward to the discussion.
Thank you so much. I think oncology should never be a destination. It's just, that's going to stick with me. So thank you so much for sharing that. It is now my pleasure to introduce one of my personal favorite people I have met since working at ACS, Dr. Sherry Young. Dr. Young is a West Virginia School of Osteopathic Medicine graduate who has held major leadership roles in West Virginia, including Cabinet Secretary for the Department of Health and Executive Director of the Kanawha Charleston Health Department, earning national recognition during the COVID-19 pandemic. She has received numerous honors, such as Outstanding West Virginian, Wonder Woman, and an honorary doctorate from the University of Charleston. She's also served as the president of both the West Virginia State Medical Association and the West Virginia Academy of Family Physicians. Dr. Young's proudest achievement is raising her daughter, Gabby. Dr. Young, welcome. So happy to have you, and I will turn it over to you for the panel.
Great. Thank you, Lindsay, so much. Always great to see you and catch up with you. I haven't seen you since Cleveland, but I had a feeling if we had 5 more minutes together, we could have saved the world. So moving on with that today, we have 4 wonderful presenters and one personal story that has absolutely opened up the conversation for rural healthcare and cancer care and oncology care for our folks. And it's so needed this day and age because so many things in medicine are evolving. And the thing that I love that our ACS folks have put together for us is that we're getting perspectives on rural health challenges from West Virginia, from Pennsylvania, from Ohio, and places that we typically think of as a little bit more urban. So I will ask for our panelists to return with us, Adrienne Duckworth, Dr. Samantha Wertz-Pelter, Dr. Jaime Palermo, and Dr. Ashley Roscoe. I'm going to be starting with a series of questions, and just in the effort to not talk over each other, we'll kind of start, I'll aim the questions towards each of you. But the first question I am curious from each of you, and we'll start with Adrienne with her work in West Virginia. What are the most significant barriers for rural patients that they face in accessing timely cancer treatments?
So my thought on that would be that in West Virginia in particular, it's getting that resource either closer to home or having the transportation to get you to where you need to be. As Penny mentioned at the beginning of the talk, a lot of services might only be offered in Morgantown or one of the larger options, or you may be traveling to Pittsburgh or Columbus for some of these different interventions. So transportation really is one of the biggest barriers. when you talk about the price of gas, things that keep patients from being able to get where they need to be. Time off work would also be another key thing, because if you're taking time and you don't have that time, you may not have the funds to be able to get where you need to go.
Absolutely agree with that. And we see that every day. And thank goodness we have allies in healthcare in other states. And so, the same question and your perspective from Pennsylvania for Dr. Wuertzpelter, what do you see as the biggest barriers that rural patients face in accessing timely cancer treatment?
I think very similar to Dr. Duckworth, but I think I'm obviously not a clinician, so I'll come at this from a different angle of the supportive care aspect. Um, I think there's a lot of resources in the community that are not cancer specific. And so if you want something cancer specific, you have to travel for it. And so when you've already been traveling for cancer care, a lot of people don't want to do extra travel to go to a physical activity program or to go to a support group in person. And so if we want people to have this extra wraparound care, we need to figure out a way to either bring that to the community or find avenues to support patients in their community, or bring it remotely in a way that is high quality and offering that same level that people can get at the central cancer center. And then another issue, like was already mentioned, travel. There's not public transportation to get you from a rural community into even the regional settings, usually the regional clinics. And so there's a lot of burden on caregivers as well that we've seen. And so some people will forego some of the extra care or this extra supportive care because they don't have transportation, or they don't want to burden some of their caregivers to get to some of these other extra visits that they could be doing otherwise.
That's great. And that is some of the work that the ACS is doing in trying to help get volunteers to take people to their appointments, because this is a major challenge that we're all facing. So the same question as far as barriers to rural patients facing access to timely cancer treatments. Dr. Wirtz, we just heard from you. So let's check in with Dr. Roscoe.
Yeah, I think one of the biggest barriers to timely diagnosis of cancer is that I think, when we think about even like if our health changes with aging, or even your own self, if you think about the ability for you to get into a primary care doctor, because primary care and family medicine, these are underserved fields. And if there is something happening or a change with your health or a symptom that's been going on, we rely strongly on this interface of primary care. But we also know a lot of people aren't getting regular routine primary care. And then when there's a change in health that's serious, or a new mass that's felt, or something that's, changing in how their symptomatology is, there's a default to partnering with emergency room services or urgent care services. And then there is a broken down communication if, and you don't want to wait until that point, right? Nobody wants to wait where they're so sick or so ill that they're seeking care in an emergency room setting, because that's a tricky place in order to be able to say, okay, there's something here, or we're worried about this, and you're either getting admitted to the hospital or you need to follow up with that. And that can be like an emotionally overwhelming time. So I think, as an oncologist, we're seeing people oftentimes already diagnosed and things like that. But I also think about the ability to, kind of the best thing you can do for yourself is to establish with a primary care physician, so you have a good inroad in the event that you do have a change in your health. And then your primary care doctor oftentimes has connections with subspecialty services, as they should. And that, to me, if any good advice, like with an aging adult or any, is like establish with a primary care. And it's hard because there's so much turnover. And then you're like, well, I did, but then my doctor changed and that kind of stuff. And that's just kind of the nature of where we're at. But I think if you can take good care of yourself in those ways, that will help in enhancing timely diagnosis of cancer, is that because you're already connected to the health system in some way.
Very well said. And so many challenges that we are looking at. Dr. Palomera, I'd like to ask you the same question about our rural patients and accessing timely cancer care.
Yeah, thank you for the question. And I agree with my co-panelists. So one thing I would say, apart from all the things I already mentioned, shortage of workforce, including lack of proper primary care providers, and also especially shortage of specialists. So I see patients with the GU cancers. So these patients, after their initial treatment, they need cystoscopy very often, and it is very difficult to travel to get the cystoscopy because there may not be several urologists in these rural areas. So that is one of the biggest barrier. The specialist care is very short. And also sometimes these people are interested in participating in clinical trials, but providers may not have good education about clinical trials. That we have seen in our recent project. About 45% mentioned that they don't know about clinical trials. They need more training. So sometimes these barriers can happen in isolation, or sometimes they can pile up. Like, for example, a rural patient, but they have like lot of travel distance, and also the provider has a poor education about the clinical trials. These barriers stack up, and that leads to compound disadvantage. So we have to take a multi-pronged approach to tackle these barriers.
Absolutely. There are multiple factors, later diagnosis, less access, and so many challenges at every level of care, and really trying to meet patients where they are. We have a lot of work to do. I'm going to move on to another question. Given the lack of supportive care and cancer-specific resources in rural communities, how can we best support the needs of rural cancer patients and survivors when it comes to diet, physical activity support, and symptom management and social support? So these can be geographic challenges, these can be socioeconomic challenges. But let's start with Adrienne. What are some of the ways that you feel like, especially in West Virginia, we can address these challenges?
So I think a lot of our patients, especially as they're coming out of their cancer care, do qualify for home health. And there are more expansion of home health across the system that can then hopefully allow them to be able to get some of that care in their home so that then they can be more prepared to transition to receive care outside of their home as they're more able. I also think that knowing the local community resources is very important. We have a strong team here that tries to make sure that if our patient needs physical therapy and they've seen the oncology specialist, physical therapist, then they make connections to that local community to try to make it so the patient doesn't need to keep coming back to Morgantown for that specific care. And because oftentimes the local area might not be as comfortable caring for a patient with cancer afterwards, they want to hear from somebody that it's okay to do these certain interventions. So it's really trying to make those connections to the local areas.
Absolutely. Also, Dr. Wuertzpelter, the same question as far as, given the lack of supportive care for cancer-specific resources in rural communities, how do you feel we can best support physical activity, emotional support, social support, the things that we are trying to get to our rural patients?
I think an important thing that we've learned is that a one-size-fits-all approach is not going to work. So I think we need to do a lot more focus on making the work that we do community-based, or have ways that we can adapt our programming for community. Another thing is to consider alternative and innovative approaches for providing these resources in the absence of a specialized cancer-focused clinic or program. So create programming or opportunities that are home-based or community-based, collaborate with the local gyms or YMCAs or senior centers. A lot of times, again, there may not be a cancer-specific program, but there are other exercise programs that are available. So like Adrienne mentioned, how can we provide the education and the resources to the local organizations or groups that are doing similar work so that they feel comfortable providing education on supportive care, exercise, diet. Another thing that we've done is work with cooperative extension or training community health workers or local volunteers to provide some of this work, empowering patients or survivors as peer educators. And again, like I shared, using wearable activity trackers or digital technology as a way to remotely provide programming or to provide remote monitoring of symptoms or activity and accountability. And of course, there's virtual support groups or programs. So how can we make sure that people have access to these? And then again, creating options. Another thing with exercise is oftentimes people make it more complicated. Just because you have a cancer diagnosis doesn't mean you can't exercise in a lot of the same ways that other people do. So I think people are scared to provide physical activity education for people who have had cancer, but it's not much different. I think we overcomplicate the advice that we give. And there are obviously caveats to that, especially depending on the type of cancer or the type of care that you received. But general exercise is good for all.
I agree for both prevention and treatment. Dr. Roscoe, do you have any thoughts on the subject?
Yeah, first of all, I just want to echo the sentiments from Dr. Wurzpelter to say that, sometimes I think we do overcomplicate things. And when we all know exercise is good, but how do you actually implement that when someone's been diagnosed with a malignancy? And I talk to my patients a lot about that. In terms of like, I'm not asking you to join a gym, although you can, I'm just asking you to walk, and so, and getting moving and kind of how movement is medicine. And those are important factors. But I think when we think about things like diet, physical activity, and supportive care systems, I love the data that was presented about how you can reach patients, because also for many providers, I mean, if you're at an oncology visit, I mean, it's a time limited scope, right? So I think you have to both from like a patient and a provider, I have my list of things that I want to cover in terms of toxicities, responsive treatments, tolerance of treatment, and if people are responding, that's kind of my list of things that I want to cover. But then I think it's really helpful when a patient or a caregiver comes in and here are my list of things that I want to cover. And then how you can kind of meet in the same way. I do love the idea of how social media can reach a lot of people, because that was one of the data points that you brought up about how people are getting their information and in their free time. And if there's a way for us to be able to continue to emphasize about good knowledge resources that come out of Facebook and out of TikTok and out of YouTube shorts and out of very formal educational pieces like this, you have to remember where your patients are getting their information too. And so sometimes if I can, I'm like, here's some resources I think that are good for you to kind of like to get involved in if you want additional information regarding behavioral supportive care, diet, physical activity, exercise, because there's also a lot of information out there that can be misguided or misdirected or actually just harmful. But creating that dialogue, and then it's helpful to people bringing me like supplements or things like that. Say, is this okay? And I'm like, no, this is not a good plan, and here's why. But here's some other resources for you. And I think that's really powerful for people. And I love the data that was presented about that engagement with social media.
Yeah, I think that's a good discussion to have because social media can have a good impact or a bad impact. And if we're going to have patients that utilize social media, let's point them in the right direction, have that discussion. So I wholeheartedly agree. And I love the fact, Dr. Wurzpelter, you mentioned community health workers and people that are in the communities that they trust. And that gives you an opportunity for some point of care testing and other, care navigation. I think is so important, meeting people where they are. So let's shift just a little bit. I want to talk about, because it came up in the presentations about telehealth and the importance of telehealth as being an opportunity. So the question first going to Dr. Roscoe, how has telehealth changed the landscape of cancer care for rural communities? You did speak to this, but expand a little bit about this importance.
Yeah, so I think it was, so COVID was all things for all patients, especially, related to cancer, but it did open up this world, right? So there was this idea that, virtual visits, telehealth, it's too cumbersome, and it really instantly opened the platforms to say that actually, no, you can provide pretty solid medical advice, in concert with, kind of where patients need to come in. But it provided this for healthcare systems to quickly allow the ability to have telehealth, whether that's through phone calls, which are perhaps less helpful, but having this kind of virtual visit for people that can't reach to a tertiary care center was very powerful. So COVID helped get healthcare professionals on board with the fact that this can be readily applied in concert with, having patients physically come in, because there's definitely times when we need to have people come in, so there's that. But oftentimes for routine checks, education, checking of people is really powerful. So, and it was time saving on both ends. I mean, I think time saving definitely for patients in terms of like their most valuable resource. And so not having to travel, navigate parking, 2 hours of waiting time, getting a caregiver there. So that all creates accessibility and from a rural standpoint. The things where I think, which are still challenges, is I think that it creates relationships, and says, this is a person that I know and trust, instead of going to like, you're going to be sent this place to somewhere to get some other thing. For us, it's transplant or CAR T or relapse therapy or clinical trial, that it creates some trust there to say that I'm in partnership with your community doctor. We work together in these ways for us to be able to work together. And I too, okay, this is like coming from Ohio, like, and have family members in Ohio. They also don't want to travel, and I want to keep them in their home too. And so I'm saying, here's like kind of big picture how I would do this. You may need some therapy with me, but maybe not right now or in the future, but I'm a connection for you and for your provider. And it helps create those kind of trusts with community teams, with with the patients that are there. So I think that's how telehealth is really powerful. But I also think there are barriers from a systematic structure about being able to reach patients across state lines, so there's some issues with that. Government shutdowns, not having Medicare patients being able to pay for telehealth, these are real things, right? And so there are some systematic and structural barriers for us to be able to deliver care that we would like to be able to do to help patients that, we have some impositions to related to systematic things too.
Absolutely. Dr. Palomera, what are your thoughts on telehealth and integration in helping navigate our cancer care for our patients in rural areas?
Yes, definitely. So we often co-manage the patients. For example, recently I saw a pregnant female with triple negative breast cancer, which is early stage but very aggressive, and she is in her second trimester and she needs chemotherapy before she goes for a breast surgery. So the community oncology provider is not very happy about treating the patient. So the patient came to see me, and we come up with a plan, and then I talked to the community oncology provider about what chemotherapy can be given safely in this pregnant patient. So I contacted via phone with the provider. We share the electronic medical health records, so they can see our plan, so we all can be on the same page about the patient care. That is extremely important. And the patient lives like 2.5 hours far away from our center, so it is very difficult for her to travel for these treatments or the blood tests or the imaging. So she can get all that care at the local provider, and I can see all those results through these shared electronic medical records. She can get the blood test there, the imaging there, everything. That is very convenient for the patient, especially she is pregnant and she is dealing with several other things. So, and also to make her comfortable, I offered telehealth, and she can share an electronic portal message at any time, so that our team from our side is always reachable to the patient.
That's wonderful. That's really tying the team together and focusing on all of their needs. Of course, that's very complicated, having pregnancy and a triple negative breast cancer at the same time. So thank you for taking good care of her and making sure that all of her needs are met, and in discussing that way that telehealth can be part of that. Also, in our previous presentations, Dr. Wurzpelter, you had spoken about telehealth. So would you like to expand on some of that?
Yeah, I don't think I have much to add. I think there's been a lot mentioned that I would say the same thing and echo those sentiments. I think there are still some challenges that we need to address. While broadband access is improving, it's not perfect and it's not everywhere. Not every rural region is the same. So what we're seeing here in Western Pennsylvania is not going to be the same even potentially as Ohio or West Virginia, but certainly not the same as Midwest or Western states. So I'll just mention that caveat that while things are improving and we're seeing higher access, it's not going to be the same nationwide. And then also, there are potentially some groups that still have problems with access. So older adults, potentially, while I shared some data that it's improving and there aren't as many differences between rural and urban, there's still less digital device ownership than younger groups overall. Digital literacy is potentially lower still. And so there's still going to be some navigation needed to help patients and survivors access the care. So having a support system available, hotline that you can call to help people navigate how to access their telehealth visit or how to get into a supportive care group that's being offered virtually is important if we want to improve that access. And also recognizing that not everyone has a smartphone, they don't have access to an app. So making sure that though this is a great avenue, making sure that we also have the same quality of care in some different avenue that could be provided and a less tech option for people who don't have access is important as well. But I'll stop there.
But I liked your slide where you broke it down, even kind of describing by age what access people have. But you do have different access to broadband, and you have different health literacy, and you have different. Even I had some trouble navigating my computer today, and so you have to be appreciative of the fact that this can happen to our older adults and younger adults as well. So thank you for that. Let's switch gears just a little bit. I want to talk about what strategies can help build trust in rural communities and cancer care deliveries. One of the things, I come from a very rural area in the coalfields of Southern West Virginia, and have been in West Virginia my entire life. I love our state, and it's been a privilege to serve here. It's been a privilege to treat patients here. But there are sometimes trust issues, especially navigating bigger hospitals. People want to be in their communities. They don't want to go to bigger healthcare centers. They have some fears there because, maybe they know somebody, or maybe there was a worse outcome because of a patient's acuity, and that's not really what they're seeing. So the specific question I'm asking, and let's start with Adrian here, because in West Virginia, I'm sure you've seen this too. How can we help build trust with rural communities in cancer care delivery?
So I think that there's several different ways that we can do that. I myself grew up about 35 minutes away from Morgantown, which doesn't seem very far, but is a big change for a lot of people. Even my own brother doesn't like to drive to Morgantown because of the traffic. They would much rather be on their windy road that they know is not going to, it might have a big truck on it, but it might not, but they're not going to sit, right? But I think we work by building trust. And I wanted to piggyback on the telehealth with the trust piece of this as well. Sure. That one of the unique ways that we can provide telehealth, or that I believe our system provides telehealth, is that sometimes the patient actually goes to the center and an iPad is brought in with the provider from the subspecialty being zoomed or through the MyChart system in to talk to the patient. But I do think just adding on to that, but in terms of adding to trust, I think a lot of times it's being honest with your patients from the beginning about what they're looking at, how you're expecting things to go, trying to be transparent, and then also trying to make sure that they understand that you want to be here in this rural or more not as urban as some areas community, taking care of people like them, that you're invested in their care. Much like you, Sherry, been in West Virginia my whole life. I think it's an honor and privilege to take care of the people from West Virginia and the surrounding areas. And I think that if patients know that, even if you're not from that area, they feel that bond with you if they know that you're invested in them as an individual, that you care about them as a person, that you listen to what they have to say, not just tell them what they should do. That it really should be a collaboration. And that's where I think oncology is the ultimate team sport, right? We're all working together to make sure that our patients get what they need. So sometimes a patient might feel more comfortable telling me as their nurse practitioner about a social issue that's going on than bringing that up to their physician, because they just don't want to take their time to talk about that. But that social issue might tremendously impact their care. So if we work together and say, hey, I understand that you maybe didn't want me to talk to the doctor about that, but I really think it's important for them to know, so that they don't feel like you're breaking that trust as well. And I think by having different members of the team that patients can relate to in different ways, that's how you make sure that patients continue to come and seek care for their cancer.
And that's such a accurate and wonderful interpretation of it. Living here as well, 35 miles makes a huge difference, and people wanting to be in their communities and roads that other people would not feel as safe on, that is their safety net. That is what people are used to. And so, understanding that definitely helps build their trust, understanding where they're coming from and what their needs are. So thanks, Adrian. I'm going to move to Dr. Palomera. Same question. Let's talk about helping build trust in rural communities with cancer care delivery.
Yes, I agree with Adrian. Collaboration is extremely important. The partnership with primary care providers, patient navigators play a huge role. So, for example, primary care providers are the first contact for the patients when they are initially having cancer symptoms, right? So they refer the patients to the oncology provider. So these patients have a lot of trust in primary care providers, and if there is something coming up from primary care providers that can make the patients more trusting their oncology care. So that is very important. And when the patient comes to the oncologist, it is extremely important to tell all the care treatment plans and work with their local oncology provider and build the trust, just like as an example I mentioned in my previous question. And patient navigators also play a huge role. Like, if the patients have any logistical challenges like transportation and financial burden, insurance issues, they play a major role. So it has to be a collaborative work, and showing up and answering them consistently also leads to having trust in their physicians.
Absolutely. And patient navigators have been shown to decrease readmissions for patients because they're helping them with that journey. And especially if they're coming from an outpatient setting, maybe in oncology, maybe for another reason, we're giving them a lot of information as they leave the hospital and they're returning to rural communities with less resources. Having somebody just to call and say, have you made that appointment? Do you have what you need to eat? Do you have what you need in your medicines? Did you receive the DME or the equipment that you need? These are huge things in that continuity of care. So, and a wonderful way to build trust. So, Dr. Palomera, I absolutely agree with that. Let's move on a little bit. I'm going to jump over the broadband because we already talked about that a little when we were talking about the telehealth issues. But first up, let's talk to Dr. Roscoe about what are the best practices for coordinating care between urban cancer centers and rural cancer providers, because that is something with the maps that we were shown, something that you deal with on a regular basis. So what are your recommendations?
Yeah, so I think that from our study, one of the things that we learned is that our perspective of what we thought some of the barriers to getting access to bone marrow transplant or specialized care were very different than when we actually talked to the centers. And so one of our first things when we were kind of connecting with some of our non-metropolitan and more rural oncology centers, we said, here is kind of our list of concerns. They're like, oh, that's very interesting because that is not our list of concerns. And that was really eye-opening to us because there were things that that become, kind of routine and normal in terms of what, what we're doing and here's an example. Like, because one of you said, are we communicating when we need our transplant needs and logistics around this? And, is this effectively getting communicated to you guys? Is it clear, what we're doing and what you're doing in terms of roles and responsibilities? And it was like, this is not the priority. Our priority is like, even getting people up there, kind of navigating, getting to a bigger city and traffic and parking and the things that we hear about, just logistically getting people there is one of the bigger challenges. And we hadn't even touched on that. And so I think when it comes to sharing patient care is really getting a better sense of where each other is coming from so we can get a clear coordination plan when it comes to kind of complex care. So that to us was really eye-opening, where we had conversations like this with the entire healthcare team, from nursing, nurse practitioners, office managers, schedulers, because it was each person plays a significant role when it comes to a cancer diagnosis. And we learned a lot from those meetings to say that, how can we help your patient population better? And, where can we fill in the areas and where are we missing kind of gaps in communication? So I think having good listening skills was helpful for us to know where people were coming from different offices and different communities.
It's a great way to tie everything together. I'm going to take the same question for Adrian on what best practices in coordinating care do you recommend between communications for urban cancer centers and your rural providers?
So I think it's really just that follow-up provider to provider. So if you've seen the patient, they were sent to your center for a second opinion, or you're trying to refer them to a local community site, it's making sure that that connection happens. I do think that that's one thing that it sounds like most of our systems are very benefit from, is that shared electronic medical record across your like hub and spoke model. So you're able to get in touch with patients or get in touch with other providers in that system. I think that that's one of the things that I, as an APP, can help with a lot, or our APP colleagues help with a lot, is that making sure that that continuity piece happens, or that those messages get sent. In a lot of our sites, we actually have an oncologist only there once a week or once every other week. So it's very important that the APP be looped in as well, making sure that handoff happens appropriately.
Very good points. Let's kind of shift gears just a little bit more and talk about the actual treatment protocols and how they may need to be adapted for our rural patients. I mean, we've got, you guys are assembling great teams of people to help support your patients. But let's talk about how can treatment protocols be adapted for patients who cannot travel frequently. So let's start with Dr. Palomera and see, what are you seeing in your practice?
Yes, so for the patients who cannot travel long distances, adopting telehealth for consenting is a great idea. It is for both standards treatments as well as the clinical trial protocols. When we are waiting for a PET scan to determine the staging, and if we do not have treatment consents at that time, but once we have the imaging results, we don't want to delay the treatment, right? So we can use the telehealth for getting consent. That is a great idea. And also the people who are on standard treatment or on clinical trial protocols, they need closer monitoring when we initiate a new drug or a new treatment. So for the toxicity check, they don't necessarily need to travel 3-4 hours unless they have major side effects. If we are just checking instead of traveling, we can use the telehealth to check up on them and making sure they are doing okay. And if they need any supportive care, we can tackle that through the telehealth.
That's wonderful advice. I am being given the nod that we need to kind of wrap it up by 10:45. So I'm going to invite our panelists, kind of their last, if there's one statement that you would like to leave our group with, something of impact that you want to get home in that last minute, please please share that with us. And let's start with Dr. Roscoe.
Yeah, I think one of the things that, we kind of started this conversation with Penny's story is about, it really is important for us as cancer providers is what matters most. And so, and if I can talk with patients about what matters most, is that getting treatment locally? Is that, talking about like, and it's not always clear and, maintaining independence, not having to use all of their time back and forth. That's really important for me as a provider. So if I can understand from a patient and family, just kind of clear, like what matters most to you, that will help kind of guide treatment decisions as a whole. And especially when it comes to treating those where I'm seeing in consultation, that is a very powerful question that I can ask patients, and hopefully you all can ask your patients this too, so we can be able to kind of meet them where they're at.
Perfect. Dr. Wertz-Pelter, any final thoughts?
I think we spend a lot of times talking about the barriers that rural communities face, and we don't spend enough time talking about the strengths in rural communities. So we've seen time and time again the strength of the social support networks in rural communities, how communities come together to help each other out. And though we talk about a lot of what rural communities are lacking, there's a lot that we can incorporate, or I think the importance here is getting to know the person, getting to know the communities that you're working with, to see those strengths and build up those strengths rather than trying to bring in what's worked in an urban community, or bringing in something that may not fit the community or the person that you're working with. So spending time to personalize care, I think, is important.
Excellent advice. Dr. Palomera, any final thoughts?
Yes, so enhancing access is enhancing hope, and to improve the access, we need to take a multi-pronged approach. So one of the models that I'm currently working on is the ECHO model. It can bridge the gap between rural and academic experts so that we can improve the education, and as a result, we can improve the patient outcomes.
All right. Very, very wonderful there. Thank you. And that's ultimately our goal. And last but not least, my fellow mountaineer, Adrienne, what are your final thoughts?
So I would say that the most important thing to me is to remember that while we're all a team for the patients, the most important member of the team is actually the patient themselves. So we have, like Dr. Roscoe said, we have to see what's most important to them and how we can fit into that and help get them where they need to be.
Thank you, Adrienne. A great job for our panelists today. I'm so happy that we were able to have this discussion. And now I will hand this off to Lindsay. Thank you.
Thank you all so much. That was so enlightening and just very inspired by the incredible group of women that we have here today. We would like now to share a little bit of information on some of the work our Discovery team is working on in the rural health space. Jordan Baker Bispo, PhD, is a cancer epidemiologist based in Lexington, Kentucky. She currently serves as a principal scientist of cancer disparity research at the American Cancer Society. She holds a PhD in epidemiology from the University of Miami and a Master of Public Health from Boston University. Her research focuses on social and structural determinants of cancer disparities, with a focus on access to cancer screening and early detection in marginalized groups. Jordan, welcome.
Thank you very much. Hi, everyone. It's such a pleasure to be here with you today. It was so wonderful to hear all of the panelists speak before me. Lindsay, can you tell me, is my background reversed, or is
Nope,
it?
you're all good. It's
all good.
reversed
Okay, for me,
only.
it appears a little bit different for me. So, okay, great. Good to know that. So I'm really looking forward to sharing more about some of the American Cancer Society's research on rural health, and some resources here that may be helpful to some of your work. You can go on to the next slide now. As many of you know, scientific discovery is among the central pillars of work at the American Cancer Society. In addition to providing funding for extramural science, ACS has a robust intramural research program with teams that focus on early cancer detection science, population science, and surveillance, prevention, and health services research. These teams engage on rural health using a really wide variety of sources, including large longitudinal cohort studies, cancer registries, population-based health surveys, and many, many others. Today, I'd like to highlight some of our recent scientific publications that address rural health, and then to draw your attention to the American Cancer Society's biennial report on the status of cancer disparities in the US, which captures really important statistics for rural-urban differences in cancer outcomes. Next slide, please. So first, I'd like to highlight a study by my colleague, Daniel Wiese, that demonstrates how structural factors, like the adoption of new medical technologies within healthcare systems, can impact rural health. Daniel's team examined the geographic diffusion of digital mammography in the United States from 2001, when the technology was first approved by the FDA, to 2014, when it had essentially replaced conventional film mammography. They used annual licensing data for mammography facilities to understand how the technology spread across different regions over this time period. And if it's possible to play this little video clip, you can see how that spread happened by looking at the green dots as they become more prevalent over time. Using rural-urban commuting area codes to define rurality, Daniel's group found that by 2014, only 30% of women in rural areas lived within a 20-minute drive to a digital mammography facility. And this was compared to virtually 100% of women in metropolitan areas. These findings really underscore challenges like high operational costs for new tech in more sparsely populated regions, and the importance of policy solutions to offset them. Next slide, please. ACS investigators also work with individual level data to understand social and behavioral factors that contribute to urban-rural health disparities. So this next study that I'll highlight was led by Dr. Erica Rees-Punya in population science, using data from the Cancer Prevention Study, which is a prospective cohort study at ACS that began in 1982 and enrolled over 1 million participants, including a subset of over 184,000 who were part of the nutrition cohort. Erica's team modeled differences in mortality risk between residents of metropolitan, micropolitan, and small town or rural areas, and then looked at how the magnitude of those differences changed after accounting for a variety of demographic, health history, and behavioral factors. Controlling for participant sex and age, they found that the risk of death was 4% higher for rural residents than metropolitan residents, as indicated by the bold hazard ratio of 1.04 in the table on the right of this slide. When the models accounted for education, alcohol use, and physical activity, those hazard ratios became null. So in other words, the higher risk of death for rural residents was eliminated after controlling for those factors. These findings indicate that rural-urban mortality disparities are partially explained by modifiable behaviors that can be addressed through multi-level health interventions, and really underscore the importance of regulatory efforts to provide safe opportunities for physical activity and guidance on alcohol consumption. Next slide, please. So I'd like to share more now about the American Cancer Society's report on the status of cancer disparities in the United States. This is a biennial report led by Farhad Islami, who is the Senior Scientific Director of Cancer Disparity Research at ACS. I've included QR codes here for the two most recent reports that were published in 2021 and 2023. The 2025 report will be published in just a couple weeks on December 16th in CA, a Cancer Journal for Clinicians, which is the flagship journal of the ACS. Next slide, please. This report features a variety of estimates that are useful for clinicians and public health advocates, particularly those who may be involved in grant writing for rural health research and program delivery. Some of the key statistics in the report include estimates of cancer incidence, mortality, advanced stage diagnosis, and risk factor prevalence using data from cancer registries and national health surveys. Rural-urban disparities are one of the main focus areas of the report, and we define rurality based on the USDA's county-level rural-urban continuum codes. Specifically, we focus on comparing estimates for large metropolitan, small to medium metropolitan and non-metropolitan areas in the report. Next slide, please. So I'm going to share some slides now with tables and figures lifted directly from the 2023 report, and these contain a lot of data. My goal is not to review all of the findings in depth, but rather to give you a snapshot of the type of data that you can find in the report, and I'll highlight some of the key takeaways. For example, this figure shows ratios of cancer incidence and mortality in non-metropolitan versus large metropolitan areas among males on the left and females on the right, stratified by 2 age groups, so adults under 65 years of age and those 65 and older. Any ratio plotted here that is larger than 1, so to the right of the vertical reference line, represents a rate that is higher in non-metropolitan areas than large metropolitan areas. Overall, in the report, we note that both cancer incidence and mortality tended to be higher in non-metropolitan areas. The disparities tended to be larger for mortality than incidence, and among adults under 65 years of age who are not yet age eligible for coverage through Medicare. Disparities also tended to be larger for cancer types like lung and colorectal that are attributable in part to modifiable risk factors like smoking, diet, and physical activity. Next slide, please. The report also includes estimates of 5-year survival by urbanicity and age among all cancer patients, and then for select cancer types. In this figure, 5-year survival rates in gray are for residents of non-metropolitan counties, and those in blue are for residents of counties in large metropolitan areas. Overall, 5-year survival tended to be lowest in non-metropolitan areas. And then in the report, we also present data showing how this pattern persisted across all stages of diagnosis. Next slide, please. To better understand some of the drivers of urban-rural disparities in incidence and mortality, the report also examines the prevalence of modifiable cancer risk factors, as well as routine cancer screening in different regions, overall and again by age group. Overall, we note that non-metropolitan areas tend to have a higher prevalence of smoking, obesity, heavy drinking, especially among younger males, and physical inactivity, and a lower prevalence of screening for colorectal, cervical, and breast cancer. Breast cancer screening disparities were especially pronounced for women under 65 years of age. Next slide, please. And then finally, the report highlights some promising directions for reducing cancer disparities through public health policy and other health and health-related interventions. Some of the directions that we discuss in the report include implementing evidence-based tobacco cessation programs and policies, increasing funding for cancer screening programs, increasing access to patient navigation services, and increasing access to telehealth for people living with and beyond cancer. So as a reminder, the 2025 report will be released on December 16th in CA, a cancer journal for clinicians. But in the meantime, you're more than welcome to contact me by email if you have any questions about the data in the report or how we analyzed it. And I think I have one more slide. So before leaving, I just wanted to mention that the upcoming report will feature mortality data by congressional district based on the most recent district boundaries that are in effect through January 2027. And I want to mention this because these data can be particularly impactful for public health advocates, especially those who are in communication with legislators and policymakers who are responsible for helping us meet the needs of the cancer control needs of their constituents. And with that, I will end. Thank you so much for the opportunity to share more about these resources.
Thank you so much, Jordan. Our researchers are the coolest at ACS, and you've continued that trend. I just love reading about the work that you guys are doing because it's so critical. And I think one of the themes that kept coming up was meeting people where they are And then again, I wrote down enhancing access enhances hope. So thank you all for your insight today. We are currently working on setting up our dates for our 2026 forum series, and we hope to send those and distribute them very soon. Be sure to indicate on your post-event survey if there's a topic you would like to learn more about. We use this feedback in our planning. We are also pleased to share that this program and all previous programs in the series are available on YouTube. CMEs are only available for the live event, but please share what you have heard today with your colleagues or check out some of the sessions you may have missed. The CME certificate will be sent out in 2 weeks once you've completed the post-event survey. The survey will pop up at the close of today's session, and you will also receive a post-event email with a recording of the session, as well as a survey link in case you missed it this morning. Thank you again so much for joining us today and for your continued commitment to fight for a world without cancer. Have a great day.